I'm Rick McGuire. I'm the executive editor of Cardiosource World News, and I'm with Dr. Alan Taylor. And you're not in your military attire, but you are here to tell me something about HDL. HDL is such a tease, you know, we know it's good for you, and yet we've had so many studies that have given us nothing but grief here recently. Have we aimed too high? What's the paper that you've presented here? What's the poster on HDL?
Well, yeah, I think the rumors of HDL's demise are much exaggerated.
Yes.
I think, yeah, we know from the science and the epidemiology of HDL that it is important. What we're lacking is some of that definitive clinical trial proof that show us that pharmacologic modulation of HDL makes a difference for outcomes. But we have a lot of intermediate steps fulfilled there, showing that different ways of modulating HDL through either HDL infusions, apomimetic peptides, and protein approaches, or drug approaches can have a lot of beneficial effects in the artery system, artery wall, artery function. I think where we are right now is asking those questions of what new drugs are on the horizon, how are they going to work? And for the drugs we have, what's their opportunity to improve cardiovascular outcomes? While I think most people would look at the recent trial failures and think that they are trial failures of HDL, I think they are trial failures. What they have is they've maybe missed the mark on some of the design elements that lead them to be a little less than informative about either the drugs or HDL. So it's like everything else. Life is a struggle against bad data, and I do think we need good data in this regard. Where we are is with 40 decades of research on HDL, or 4 decades of research on HDL. We still need more. We need those pivotal clinical trials that create the burning imperative to clinicians that they need to pursue this. And right now we're lacking that burning imperative. Even the guidelines, although they permit us to treat HDL, and they encourage HDL treatments, they don't tell us what our goals are. And we're so goal-directed in clinical medicine right now. Until we know HDL is this and should be that, we're not going to approach it. And we need those trials that tell us that. So HDL, you're right, it's a tease. It tells us, we know it's risky, we know it associates to risk, we have some ways to treat us, but the burning imperative is a little bit degraded right now. But I think we need to keep the fields continuing to move forward, and we'll learn more in the coming years.
So what work have you done specifically that makes you optimistic?
Well, the work we've done is with drugs to modulate HDL, niacin in particular, in which show us that if you can use niacin successfully, that arteries regress in terms of atherosclerosis. It appears beneficial. It adds to conventional therapies like statins. And I think that's the hope. That's the promise. But we have to translate that to clinical outcomes. Those are not outcome studies. And what we need is those good, solid outcome studies that answer the question. So, there is a need for this. There are, 1 out of 4 U.S. Americans has metabolic syndrome characterized by low HDL. Huge and growing problem. There's enough risk here. We should learn how to treat it and treat it well. In the meantime, patients should still approach their heart disease risk as a multifactorial problem, and this is just one element of that.
There's still a need to focus on this. Clinically, there's still a need.
The guidelines haven't changed, and I don't see a need for them to change. The data that informed the guidelines from the past are still valid and present. What we haven't done through recent trials is extend the imperative, but I think we need more data before we can really close the door on HDL and say we shouldn't be treating it.
In general life, we have bad days. In cardiology, we have bad data sometimes, and don't get depressed. Keep listening and reading about HDL because there's more to go, more to come.
It's a promising area.
Terrific. I'm Rick McGuire with Dr. Alan Taylor. I'm the executive editor of Cardiosource World News. Thanks.